Hi, everyone, and welcome to our program today. This is Richard Mollett, Executive Director of the Long-Term Care Community Coalition. Before we get started, a few meeting tips. Again, please put any questions you have in the Q&A at the bottom of your Zoom screen. You're welcome to use the chat for conversations, but we will not be, monitoring the chat for questions, and we don't have the ability to take live questions. So please put any questions you have in the Q&A. If you have any technical issues, please let us know about them in the chat, and we will address them as expeditiously as possible. On the right-hand side of the screen are a couple of the new programs that we have coming up, or actually in the past was a January webinar, which is now available on our YouTube channel. And we have new data on antipsychotic drugging that we just got from the federal government for the second quarter of 2021, and a really wonderful podcast. I actually listened to it over the weekend, The Cornerstone, The Builders Rejected, Why Reform Starts with Person-Centered Care, featuring our friend Kathy Encino. A little bit about LTCCC, for those of you who may not be familiar with us. We are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in long-term care facilities, nursing homes, and assisted living in particular. Our focus is policy research and analysis, and through that we do systems advocacy. We also more and more over the past 10 or so years have been doing public education, such as these monthly programs and fact sheets and the aforementioned podcasts, et cetera, that are available on our website. And we are also the proud home to 2 local long-term care ombudsman programs. Our website, of course, is nursingHome411.org. Everything on the website is free to use and share. I am really excited about today's program on assisted living. We were just talking before we got started that we haven't done a program on assisted living, I think, in about a year. So this is great. Today's program is entitled Identifying Policy to Promote Quality Assurance, Safety, and Quality of Life. The program materials are available on our website, as you can see here, nursingHome411.org/webinar-assisted-living. And we will be posting it by the end of the week on our website, the recording, I should say, on our website, as well as our YouTube channel. We have a special guest speaker today, Paula Carter, who I'm very excited about, Dr. Carter is a professor, and I wrote this down to translate the OHSU, is Oregon Health and Science University, Portland State University, and she is the director of the Portland State University's Institute on Aging. Dr. Carter studies how state and national policies for assisted living, adult foster care, and publicly subsidized housing affect the lives of older adults. She's published over 50 articles on these topics, and her work, I should say, is a resource that I turn to over and over again. And she is just a marvelous researcher and resource for those of us who are concerned about assisted living and interested in assisted living, those issues. And she lives in Portland, Oregon with her husband, teenage daughter, 1 terrier, and 2 frogs. We're not talking about the frogs before. We were talking about our common interest in terriers. And without further ado, I am going to stop sharing my screen and allow Dr. Carter to begin.
Great. Thank you for that kind introduction, Richard. Can you see my slide?
Yes. Ooh.
Okay, great. So, okay, I'll go ahead and get started then. So in 1990, I was a research assistant at the Philadelphia Geriatric Center, and the director, Dr. Pal Lawton, who was an environmental psychologist studying the relationship between living environments and well-being, was informed by the theory of person-environment fit, which is shown here and probably familiar to some folks. It looks at the relationship between the physical environment, the individual, and the person's well-being and health outcomes. So Dr. Lawton wanted to know how nursing homes, memory care units, and neighborhoods affected the well-being of older adults. When I told him I was moving to Oregon, he introduced me to Karen Brown Wilson, who was developing a new form of residential care. It was called assisted living. So I began working with her and Michael Deshane, the CEO of Concepts in Community Living. They had collaborated with Oregon state policymakers and advocates to develop administrative rules that included a social model approach shown here on the slide. The model borrowed from the disability rights literature as well as person environment fit theory, and it emphasized residential, non-institutional environments and the rights of adults to make choices, even ones that others might consider to be poor or dangerous. Their early work of assisted living included convincing policymakers, developers, fire marshals, building inspectors, and many others that it was okay for older adults, including those who had moderate to severe physical and cognitive disabilities, to live in an apartment with a locking door, operable windows, temperature controls, and a microwave oven. In the 1990s, there were many forums, working groups, newspaper exposés about what assisted living was, should be, or could be. Today, in part due to the pandemic, we are again prompted to ask these questions. So what is assisted living? Why are we focusing on it? People preferred living in their own home with support from family, friends, and paid services if needed as they age. If doing so becomes too challenging because the person has physical and or cognitive impairments, needs assistance taking medications, can no longer drive, among other reasons, then assisted living provides an attractive option. The number of assisted living communities and residents has increased since the 1990s. So here's a brief outline. In the next 35 minutes or so, I'll briefly describe what assisted living is, who lives there and works there, how much it costs. Then I'll focus more on how states regulate assisted living, the impact of policies on resident well-being, and what some current policy issues are. And then at the end, there are some references and resources in the final slides. Generally, there's agreement that assisted living is a type of congregate residential setting where people live in private or possibly semi-private units. Among the items on the list in this slide, a key feature is access to staff who can assist with unscheduled needs. That could include an acute onset of symptoms like pain or stomach upset at 2 o'clock in the morning, or for the night owls, a late night snack or someone to talk to and maybe play a game of cards. In 2003, the Assisted Living Work Group put out a report. It was a consensus document produced by 50 member organizations, and they made recommendations on assisted living quality to the Senate Special Committee on Aging. They addressed the 8 topics listed on this slide, and then underlying topical areas were several themes, including those at the bottom of the slide. So person-centeredness, dementia care, quality. I'm going to return to these topics throughout the presentation. The important thing to note here is that the report is a resource for states, advocates, and assisted living operators because it represents a wide range of constituent groups, including senior housing professionals, healthcare professionals, government agency staff, and advocacy organizations. And I have a link to that in one of the final slides. This is just a very brief overview of demographics and care-related needs based on a national study conducted by colleagues at the National Center for Health Statistics. The majority of assisted living residents are white and non-Hispanic, female, and age 85 or older. Over 60% receive help with 3 or more activities of daily living, or ADLs, and only about 1 in 5 are Medicaid beneficiaries. Affordability and access to assisted living is an important public policy topic, and there's broad variation across the states. For example, in Oregon, where I am, about 44% of assisted living residents are on Medicaid. We know as well that that individuals who have Alzheimer's disease or other forms of dementia reside in assisted living. I'm focusing on this rather than other diagnoses because assisted living has become a very important setting for people living with dementia. So, and I just want to make a note that in some slides, you'll see ADRD for Alzheimer's disease and related dementias. In addition, I might sometimes say AL rather than assisted living during the presentation. And then about the costs. So costs of care vary dramatically across the country and are dependent on a number of factors, including real estate and cost of living in a specific region, staffing models, and additional services that an individual resident either chooses or needs. For example, a resident with a pet, maybe a small terrier, might choose for staff to clear the litter box or walk the dog. That costs extra. A resident who wants staff assistance to take a daily shower rather than the 2 per week typically provided might be charged a higher fee. That said, the monthly median costs based on a national survey for assisted living in 2021 was over $5,000 a month and over $64,000 annually. And I attempted to look at some New York zip codes because you can do that on this Genworth website. And so you can see the range here from 4,500 to over 5,700 in the New York area. And then when you look at memory care, that can add 20 to 30% to the monthly costs, resulting in an annual fee of more than $83,000 per year. In addition, assisted living communities may charge additional fees, one-time fees, and communities use a variety of fee structures. Some charge a flat monthly fee, others use service levels, some use a la carte where you choose the services that you want. So there's a lot of variation there in terms of how fees are structured and what the amounts are. So a little bit about who works there. And actually, I'm going to focus on this quite a bit in this and coming slides. So personal care is a major focus of assisted living. Therefore, it's no surprise that most of the care related staff are aides. And there's various terms for individuals. Direct care workers oftentimes used. Most often, these are individuals who do not have a certification or license, but have training. So most states do not require licensed nurses to provide direct care, though many states do require licensed nurse presence, primarily for oversight, monitoring, as well as training and support of the unlicensed care workers. Based on a review of regulations in effect in 2015 in the United States, we summarized 2 medication administration policies, and these are shown in the bar chart to the right. We looked at who may administer medications and what are their training requirements. In states with more than one form of assisted living, we focused on the regulation for the setting that permits the highest level of care. So the bar chart is a count of states. It shows that in 2015, 36 states permitted unlicensed care aides to administer medications to residents in at least one type of assisted living in that state. And of those states, 26 required medication aides to complete some form of coursework style training. 8 states permitted the RN, registered nurse, to teach medication administration through delegation. And for 3 states, the rules were either silent or unclear. I just wanted to make a note as well that states that allow unlicensed care aides to administer medications typically have restrictions on that. For example, most commonly that unlicensed care aides might not be permitted to administer medications through injections. So I'm going to be talking quite a bit about regulations, a topic that I think is very interesting. So, and I've spent a lot of time reviewing and thinking about. So there's little federal oversight, and I'm not going to talk about that today. I could answer some questions about it at the end. We have long known that states define and license more than one assisted living type, and that states use a variety of licensing terms. One national survey of monthly assisted living costs identified 70 different licensure names used by states, and fewer than 40 of those actually use the term assisted living as part of the license designation. So our research, using a novel method called health services regulatory analysis, found that states use an even larger number of approaches to license and oversee assisted living. As shown in this slide, of the 182 licensure classifications, we identified 45 that apply to a primary license for assisted living, 71 to subtypes, and 66 to designations applied to a primary or subtype. And these classifications can be combined in 350 different ways by state regulators. And I'll show you an example on the next slide. So generally, though, it would be a primary license would be something like assisted living, and then a subtype might be something like level 1, level 2, and a designation might be memory care or another type of designation. There are a few states that designate communities for individuals with certain mental health conditions. Excuse me. So here's a couple of examples, and that shows you how we get to the number of 350 different approaches that states use to license and oversee assisted living. So Oregon, for example, has 2 primary licenses, residential care facility and assisted living facility. And then they have a memory care designation that could be applied to either one. So there are assisted living and residential care communities that can tally up to 4 in this way. New York is somewhat more complex. The state has 5 license names and 2 designations that can combine in about 30 different ways. And I'll show you, this is not a very attractive slide, and but I just wanted to provide some of the level of detail that we have and that we use for analyzing results, and you'll see some examples of this in a couple more slides. So New York, first I'd like to say I'm not an expert in New York policy, and there's probably nuances that I will miss, and my understanding is that not all of the license names on this slide would be recognized as assisted living, in air quotes, by everyone who works in the senior housing arena. However, all of these meet the definition of congregate residential care settings that provide 2 or more meals, and that provide settings for adults. So New York has a single primary license called adult care facility, and then there are 2 sub-licenses, adult homes and enriched housing program, and either of those may have an additional license for assisted living program, which is the state's plan managed care program, assisted living residence, and then the assisted living residence can have either or both of certificates called enhanced assisted living, special needs assisted living, and then in addition, adult homes may also have a certificate for transitional adult home. And that, as I understand it, was created to assist with individuals who are moving out of state hospitals. So just to summarize New York, and then I'll give you some additional examples, these can be combined in numerous ways. Doing so allows assisted living operators to offer consumers more options based on their needs, interests, and ability to pay privately or with public resources. It also allows different regulatory agencies to target services to specific population groups. Does this approach increase regulatory complexity? Possibly. That's a question for another day, and I'd be interested in hearing what others think about that. Okay, now I'm going to start summarizing some results of some of the work that our team has done. So just knowing that a state has dementia care regulations does not tell you all that much. We've looked into states' requirements for direct care workers and administrators' initial training in dementia care, and whether cognitive screening is required at admission. And that's what this slide summarizes. As of 2018, 24 states lacked dementia-specific training requirements for administrators. 11 had this requirement only in dementia-certified assisted living. 5 required this training for some license types, and 11 states required it for all assisted living license types that they have in their state. So I was looking at the second row there for those figures. And then you can see, for example, cognitive screening at admission and the variation there. So the next slide goes into more detail for administrator training. So our study looked at changes in regulatory requirements over time. In 2007, 19 states required dementia-specific training for administrators. Of these 19, 11 required training in all licensed, 3 in some settings, and 5 in only dementia-designated settings. So that was in 2007. And then between 2007 and 2018, 10 states modified their rules for assisted living administrator training in dementia care. This increased the total from 19 to 27 that had these requirements. However, the number of states in which all licensed settings required administrator training was still 11, because most states added the requirements for only a subset of assisted living communities. In comparison, we have at the bottom right corner of the slide, earlier analysis that I did that was based on 2015 regulations. And it focused only on assisted living settings that permitted the highest level of care for each state. And at that time, only 8 states required dementia-specific training for administrators. So what does this mean? First, I want to point out that we're talking only about regulatory requirements and not what individual communities do in practice. And second, having requirements specific to dementia care settings is a good thing. But we know that assisted living that is not designated for memory care certainly has residents with cognitive impairment and dementia. Work by Cheryl Zimmerman and colleagues at University of North Carolina indicates that the majority of AL communities in the United States do not segregate residents with dementia from the general population. In addition, the National Center for Health Statistics reports that about 1/4 of AL communities had more than 3/4 of their residents diagnosed with Alzheimer's. So that tells you that there are plenty of residents in general assisted living who have some level of cognitive impairment or dementia. And for that reason, you would hope that staff and administrators have training in dementia care. And I'd say the variation in dementia-specific requirements is concerning given these realities and the growth of the memory care sector over the past decade. Most states do have regulations defining administrator qualifications, and all states have training for direct care workers, aides, and other hands-on care staff. But just with all aspects of assisted living, there is wide variation across and within the different types of assisted living in terms of training. So as an example, this is from New York, and this is the text from the regulatory requirement for assisted living residents with special needs for New York for resident aid training. And what it shows, well, first, the designation can be used for assisted living residences that provide memory care to people with Alzheimer's disease. And while the rules here do not specify dementia care training, the underlying text indicates that the state does want resident aides to receive training in topics that relate to their job responsibilities. In an ALR for people with Alzheimer's, this suggests to me that the 12 hours of training, or at least some of those 12 hours, would be in dementia care. I did a little more digging and I found a memo on the state's licensing agency website that clarifies the following for this license designation. And so you can see the underlined parts. It does refer to having some training in the needs of persons with dementia, including behavioral symptoms, mental and emotional changes, and that it should be individualized. So looking at this text leads me to talk a little bit more about an approach that we've been using with our team. So this slide shows some of the regulatory requirements for training all staff who work in Oregon's memory care communities. These regulations are far more detailed. This is only a section of, of the text so that for the purpose of demonstration. There's also additional training requirements for administrators, direct care workers, and nurses, including nurses who work on call. And I'm showing this slide not to suggest that these regulations are better than others, but as an example of regulatory specificity. And regulatory specificity refers to the level of details in the regulations, such as requirements for staff training. Do the regulations specify how many hours of training, continuing education requirements, whether a performance or written exam is required? States may specify that operators should employ sufficient numbers of staff, or regulations might get detailed on what does sufficient number of staff mean, or specify staffing levels or ratios. Some policy studies examine regulatory stringency, which typically includes the breadth of the regulations, oversight procedures, and penalties associated with noncompliance. Whether to focus on regulatory specificity or stringency depends on the research question. But the big question is, what difference do regulations make in terms of residents' well-being and health outcomes? So here I'm going to talk about some of the research that our team has done. And these are, you'll see many of the team members here on this slide, and the research that was funded by a grant to Dr. Callie Thomas at Brown University from the National Institute on Aging. We've been studying the impact of state regulations on assisted living resident health outcomes for the past 3 years. So I'm briefly going to summarize results of these papers, and there's links in the final slides. So one of the papers, it was led by Dr. Thomas, describes where assisted living residents died and whether they used hospice services in the last 30 days of life. The study used claims data for a cohort of over 40,000 residents enrolled in traditional Medicare who died in 2016. Nationally, 57% of this cohort of AL residents who died in 2016 died in the assisted living residence, and therefore did not die in a hospital or nursing home. Of the 40,000 who died, just over 45% died in the AL with hospice care, and 12% died in the AL without hospice. About 1/4 of the residents who died were transferred to and died in a nursing home, and 16% were in the hospital at the time of death. Some resident level differences in place of death were observed. For example, residents who were dually eligible for Medicare and Medicaid were more likely to die in a nursing home or hospital. And in addition, the study identified state level variation in place of death. The number of days a resident spent in assisted living with hospice services in the month before their death ranged from 13.5 days in Utah to 2.1 days in North Dakota. Utah is one of several states with regulations that allow AL communities to both admit and retain residents who receive hospice services. North Dakota's end-of-life care regulations for assisted living require that the community must be certified for end-of-life care, and the resident must elect to receive this care from a licensed and Medicare certified hospice agency. If the resident is not capable of self-preservation during an emergency, the AL community must inform the licensing agency and comply with National Fire Protection Association building requirements. We don't know the extent to which these or other requirements either encourage or discourage the use of hospice services, but the difference in number of days in using hospice services between Utah and North Dakota is noteworthy. It's also important to understand that nationally, 57% of AL residents with traditional Medicare who died in 2016 died in the assisted living. This indicates that these communities serve residents who are frail and at the end of life. We know that residents typically prefer to age in place, avoiding transfers to a nursing home. Among the residents who died, more than 3/4 received hospice in the last 30 days of life, which is generally a positive finding, although we need more details about the quality of hospice services delivered in assisted living to better understand the resident experience. Another paper, this one was led by Portia Cornell, compared nursing home and hospital admissions among residents with Alzheimer's disease and memory care assisted living to those in general assisted living. The sample included Medicare beneficiaries with an Alzheimer's disease diagnosis who moved into the AL community between 2014 and 2017, and in one of 22 states in which we could identify site-specific memory care designations. To assess the impact of memory care, the team identified a sample of residents who moved to memory care assisted living. The final sample included over 20,000 people with Alzheimer's who moved into assisted living, of whom 39% entered a memory care community. The analysis then looked at the characteristics of residents who had a hospital or nursing home admission within 6 months of moving into the assisted living or memory care community. So after adjusting for clinical acuity, dual Medicare, Medicaid enrollment, socioeconomic characteristics, the team found that residents in memory care were less likely to have any hospital or nursing home admission within the first 180 days in assisted living. The hospitalization was lower for memory care, representing a 7% difference from the average among residents of general assisted living. And when adjusting for covariates, the memory care residents' lower risk of nursing home admission represented a 16% decrease relative to general care. These findings suggest that memory care admission could be protective of transfers to hospital and nursing homes for at least some residents with dementia. Possible factors specific to this setting, such as staff training and supportive building design, might account for some of these differences. In addition, given that nursing home stays are more expensive than assisted living, it might be that public payers might be willing to pay more for memory care to prevent the downstream costs of nursing home care to the state's budget. Most states do use Medicaid to pay for some assisted living care, although programs are limited in terms of the number of slots available, geography, and several other restrictions. And as an example, in 2021, Oregon reimbursed assisted living at just over $1,400 for the lowest level of AL care and nearly $3,400 for the highest level of AL care for a Medicaid beneficiary. And then memory care operators received a flat rate of $4,700 per month, nearly $1,400 more per month than the highest service level for Medicaid beneficiaries with dementia. In contrast, the reimbursement rate for nursing homes in Oregon was just over $10,000 a month. So limiting nursing home use can save states money in some cases. So I'm going to talk more about the staffing, the final paper listed here on the next slide. So as I mentioned earlier, we've been looking at how specific regulations are and what difference that might make. Dr. Thomas and the team examined the impact of regulations for care-related staff on residents' hospital use. And this slide just shows how the regulatory specificity was scored for direct care workers, and we use the same approach for scoring LPN and RN requirements for each state. And given that our outcome of interest was hospitalization, we felt that focusing on care-related staff requirements was a better approach than, for example, looking at frequency of licensing inspections, which might be a regulatory stringency approach. So the article was published in Health Affairs, and the team compared changes in the specificity of staffing requirements between 2007 and 2018, finding that increased regulatory specificity for direct care workers was associated with a 4% reduction in monthly risk for hospitalization and 6% reduction in monthly risk for the subgroup of residents with dementia. In contrast, the increase in specificity for LPN requirements was associated with a 2.5% increase in per month hospital admissions for general AL and 5% increase for residents with dementia. Findings regarding RN regulatory specificity were not significant. The results have striking implications for AL policy and practice because this 4% relative decrease in monthly hospital admission risk that was associated with an increase in the specificity of direct care worker staffing amounts to a 30% of the total change in mean hospitalization risk between 2007 and 2018. The finding that increased LPN regulatory specificity is associated with increased costs might seem odd. However, this finding has been seen in nursing home research as well. Some thoughts about the reasons are that if regulations result in higher LPN use, some communities might substitute these more expensive staff for lower wage workers, such that there could be insufficient staff needed to provide hands-on assistance, or it could be that LPNs might identify signs and symptoms of declining health that lead to hospitalization based on their training skills. However, we don't have access to staffing levels or patterns in assisted living communities, and so future research would need to look more deeply into those issues. So in terms of this staffing variation, I just wanted to show the counties in New York between 2007 and 2018. So the darker color shows the highest specificity. And so this slide shows how changes in regulations could increase specificity within a state in some areas more so than others, depending on the geographic distribution of different assisted living license types within the state. Okay, so now I'm going to transition to talking more about state oversight and reporting and then current policy issues. This slide shows the results of a national survey of state licensing agency staff that our team conducted in 2019. The survey asked questions about the frequency of licensing inspections, state response to licensing inspections, data collected by states about residents and staff, and then public disclosure of information about assisted living. The good news is that most states conduct an annual or biannual inspection, a licensing inspection, and they require a plan of action and follow-up review after the correction period. Just over half of states compile data from assisted living communities. We gave them a list of data types that they might compile, and those were low. So 12 states collected information on resident falls, only 2 collect data on staff turnover. And these items can help states as well as AL communities assess quality of care and the need to review and make changes, for example, to staffing levels or staff recruitment and retention strategies. In addition, the survey asked what information states make available to AL consumers about violations, which is another indicator of quality. The most common strategy used by 32 of 48 states that participated was to post the violation inside the facility. So certainly there is some room for improvement in that. A 2020 study by researchers at the University of South Florida reviewed all states' websites for the presence of information about assisted living characteristics, payment and services, and quality. Most states provide basic information about assisted living communities, such as size and ownership. Only 35% of states listed payment types accepted, and 31% included memory care availability. So while 70% posted inspection results, only 43% included information about consumer complaints. The authors of that study noted that in many cases, finding this information on states' websites was burdensome. Okay, returning to the 2003 Assisted Living Workgroup report that I mentioned earlier, we recently reviewed state policies that meet the 90 recommendations made by the report authors in 2003. So the map to the left shows the number of specific assisted living workgroup report recommendations that we could find in states' regulations before 2003, and the map to the right is shows a review done in 2018. In the 15 years since the report was published, 17 states put in place at least 50 of the 90 recommendations, and 20 added between 41 and 50. So those are represented by the darker colors for at least one assisted living licensure category for the state. So this suggests that at least some states are updating their regulatory requirements with the goal of improving resident safety and well-being. And then going on with more about the assisted living work group, the primary goal was to improve quality in assisted living. There's many reasons to track and report quality indicators in assisted living to identify and correct potential problems, to inform consumers, and to provide detailed information that regulators and insurers might request. Rhode Island requires assisted living residences to establish a quality assurance committee comprised of the administrator, a nurse, a dietary staff member, and to develop a quality assurance plan that is reviewed and updated at least annually, and to develop criteria for monitoring resident and family satisfaction and plans of correction. Residences that specialize in dementia care have additional quality assurance requirements. In looking at what states mandate, we could identify only 3 states that currently mandate assisted living communities to report data to a licensing agency: Ohio, Oregon, and Minnesota. 2 states have voluntary reporting programs. Wisconsin has systems in place to collect, track, and report information about quality measures, and New Jersey has a voluntary program for operators who meet defined benchmarks based on quality measures. In addition, Florida, North Carolina, and Washington have quality initiatives in place. These 8 states' quality initiatives, as well as quality programs by accrediting and senior housing professional organizations like the National Center for Assisted Living and the SEAL, can identify or can guide other states on how best to implement programs designed to improve quality of care and well-being for the hundreds of thousands of assisted living residents in the United States. So I'd like to transition to the final topic, which is thinking about current issues. And so obviously, as I mentioned at the beginning, the pandemic has had a large impact. This slide, sadly, shows the excess mortality among assisted living residents during the first 8 months of the pandemic. After adjusting for facility effects, assisted living residents experienced 17% higher overall mortality in 2020 compared to the year prior, and 24% higher mortality in the 10 states that had the greatest community COVID-19 spread during the study window. So you see the orange bar, or the orange line, is the 2020. And so these results suggest that assisted living residents experienced increased mortality during the pandemic, consistent with increases seen among nursing home residents as well. The increase in resident mortality is likely an underestimate of the overall excess mortality during the pandemic, given the lag in vital statistics data that were used to do these analysis. We also reviewed states' assisted living regulations for infection control policies effective in 2018 and identified 31 states with policies such as the use of universal precautions, reporting, and staff training in infection control measures. 6 states directly referred to resident isolation practices for communicable diseases. There's 2 caveats here. We do not know to what extent the variation in infection control policies affected resident outcomes, and it is possible that states have infection control policies for all or most licensed settings that would apply, but that were not directly described in the assisted living regulations that we focused on for our study. So for example, they could have external requirements through a public health department that we would not have seen because we were looking specifically at the assisted living regulations. So the pandemic, it's not the only factor, but it certainly has prompted increased attention, and policymakers, researchers, advocates, assisted living residents and their families have all called for renewed attention to assisted living quality and resident well-being. What hasn't been shown in the slides today is the many hours that residents were and continue to be isolated, and the significant challenges faced by and overcome by assisted living residents, administrators, and staff. I want to emphasize and recognize the losses that they have suffered since March 2020. As I mentioned, recent publications have identified the numerous overlapping tensions for change. This one from Cheryl Zimmerman and colleagues depicts how forces such as financing, resident acuity, workforce challenges, different assisted living models and regulations intersect. Future policies and interventions need to account for these overlapping tensions. And I wouldn't be a researcher if I didn't include a slide suggesting future research, which is outlined in this article by Sagel and colleagues. The slide is organized by the person environment fit model that I shared earlier. To achieve optimal health, quality of life, and consumer expectations requires balancing the person's needs with the larger environment, including the organization, the policy, and cultural aspects. We need to know more about resident experiences of assisted living, including how the variation in assisted living types within and across states affects well-being, and perceptions of person-directed care, as well as access by underrepresented groups as the older adult population in the United States becomes more diverse in terms of race, ethnicity, and immigration status, among others. Here again is that person environment fit model, which I put in because this slide is organized in that way. So in sum, assisted living is an important sector of the long-term services and supports arena. In the 30 plus years since the current assisted living model was developed, many things have changed. States continue to license and monitor. Consumers continue to choose these settings. People often ask if I think that federal regulations are needed. Given the diversity of regulatory approaches and setting types used across the United States, overlaying one federal mandate might not succeed and would need to be done carefully. So to close the slide presentation, I'd like to share a few slides that depict variation in assisted living settings. These are photographs that I took, so please keep in mind that quality could be better. So this might look like a familiar entry to an assisted living community anywhere in the United States. Here's an example of a little bistro. And then here's two different types of apartment units. The one on the left looks more like a apartment with a kitchenette, a tiny dining space. And the one on the right is a board and care community in Washington State that's double occupancy. This is a couple of examples of how medications might be administered. On the left, there's a medication room with charts and binders and fax machines. And on the right is medication sitting on the kitchen counter in a residence apartment in an assisted living community here in Oregon. Not a very pleasant picture, but that shows variation in the quality of bathroom facilities in different setting types. And again, just a little window into someone's individual apartment. Here, a resident was displaying to me their sock grabber that they used so that they were able to pull their socks up. Different dining experiences. So the one in the upper right is one in the basement of a residential care community. They do not allow people to come into this space except during meals. The other one in the bottom right is, you can see the glass settings and maybe you might be able to see the linen napkins on the tabletop, and the one to the left is somewhat more moderate. And then here's two examples of community spaces. The one on the right is a residential care community in Oregon where many of the residents are Medicaid beneficiaries. The one on the left is in Massachusetts, and it's sort of in a nice neighborhood of Boston. And here are the references. So I will stop sharing. I think Richard might have some questions.
I do. Just 1 second. I'm going to share my screen. What did I do with that? Oh, here we go. Oh, thank you. So thank you, Dr. Carter. This was really excellent. So interesting and thoughtful, and you could really see how much that you're thinking about these issues. And I think for me, at least, to see the different levels in which we all could be thinking about this, it's there's so much going on, and I really, really appreciate it. Thank you very much. I thought that I would just quickly mention some of the resources that we have on our website. So many years ago, actually about 20 years ago, we developed with the Coalition for the Institutionalized Aged and Disabled, a series of assisted living guidebooks that are focused on fostering independence and choice. And there are 4 guides. One is for prospective residents. The second is for current residents. And then there are 2 guides for operators. One is for owners and managers, and the other is for direct care staff. And if you go to our website, as you can see here, the assisted living page in particular, you could download those guides. We just updated them about a year or two ago. Maybe it was a year before the pandemic started, so maybe it's been 3 years now. And we also put together some of the resources from those guides, like questions and answers that you might want to ask when you're visiting a facility or working with the facility. We separated them out as downloadable files for people who want to take a Q&A sheet with them when they go to a facility. We also have a report, and this was actually a lot of it derived from information that Dr. Carter had researched on promising policies and practices among the states on assisted living. And we have a few fact sheets, and again, our prior webinar is there. So that's just some of the things that we have. Before we move on to Q&A, our next program will be Tuesday, March 15th at 1 p.m. Eastern. Very interested in this program myself. It is called, A Matter of Justice, Racism as a Fundamental Cause of Long-Term Care Inequalities. And Dr. Fashal Walters will be presenting there. You could see here to register. It's a bit.ly link, but you can go to our website, of course, where the webinars are, and just follow the link there to register. Here, the materials for today's website for today's program are available on our website. And here's the information for our other programs. And then I'm going to open it up to Q&A in a moment. If you are a long-term care ombudsman and your ombudsman program allows you to receive credit for this, please fill out the short survey, surveymonkey.com/r/LTCCC-LICCOP1. And if you are an ombudsman program supervisor, just let us know if you'd like to be included in this, and we'd be happy to include you to provide our programs as credit for your staff and volunteers. So I'm going to move on to Q&A now. I actually have the first question. I'm going to take the host's privilege and ask it myself. And that question is, you were talking a bit about memory care, and that's something that's kind of it's kind of stuck with me for a while now. Like, what is memory care? I'm just, I'm not asking you what memory care is per se, but I guess I would be really interested in your thoughts and experiences in looking at state rules and policies, as well as individual facilities, in terms of how we should be understanding it, both maybe as consumers, from a consumer perspective, but also from a policymaker perspective, because I think memory care is really open-ended, of course, and so just some of your thoughts would be really welcome there, and then I'll move on to other people's questions.
Okay, thank you. Well, I'd say this is largely informed by my experience in Oregon. And one policy change that was made here in Oregon was that the requirement is that for an individual to live in a memory care community, they have to have a diagnosis of Alzheimer's disease or related dementia. So that creates some challenges. There's some good things about it, because then you can focus your attention and know that this is a place that provides memory care, and that the staff have, specific training, and the administrator and all of that, which is good. But some of the unintended consequences of that approach are that spouses are, it is possible to get a waiver for a spouse to live in a memory care community with their partner, or partner, not necessarily spouse, but it does create some challenges for couples, when that occurs, and if to the extent that they both want to live together still, and in memory care. And then the other unintended consequence, I would say, is that for smaller communities, rural communities in particular, it might not make as much sense to have a separate memory care community and a separate general assisted living community, just because of economies of scale and staffing. And so if you have this mandate that only people who have a diagnosis may be admitted, then it creates challenges to, I'd say, not-for-profit and small and rural providers in particular. The other thing is just kind of stepping out and looking at the bigger picture is that a lot of the memory care rules that states have are not so much about how to, you know, define and deliver dementia care, but rather to disclose information to consumers that what that community thinks memory care is. And so, here's our staffing, here's our programming, here's the services that we provide, here's how we do meals, but it doesn't, the state doesn't necessarily say, here's what you must do if you're memory care, just that you must tell consumers what you do. So I think that we need to have more understanding of what the best approaches are for defining and overseeing memory care.
Thank you. Thanks very much. There's actually also another question on memory care. How can we find out if our memory care staff has done any continuing education in dementia, et cetera? They won't seem to answer except claiming they do, but certainly don't seem like they have any training.
Well, so that's interesting. And I think that must be a common issue. I know that here in Oregon, the legislature actually mandated that that assisted living and memory care communities have to start reporting the staffing received by, or the training received by all their staff. So that is actually going to be collected as a quality indicator and will be reported. So the state actually set up a tracking form for providers to use that captures the staff training and all the requirements, not just memory care, all like universal precautions and everything else. So I would think, though, having some sort of, like a certificate of completion, like if you took an online course, something through the Alzheimer's Association, at least a screenshot or something that shows that the individual has completed that. That said, I teach online classes, and I know that students can log into the class and then probably walk away. So it doesn't necessarily mean that they were sitting there, absorbing the content.
Yeah, interesting. Thank you. So this another question is looking for your input on best ways and practices to improve care regulation oversight for residential care facilities, since it is so difficult. Particularly interested in memory care. Our memory care even has a medical director, though we have never seen or heard from him.
Yeah. So, well, this is what we're looking at, in terms of our research and trying to understand, what difference do regulations make in terms of resident outcomes, and so far we're only looking at things, big picture things like hospice use and hospitalization and nursing home care. But you could also look at, doing surveys of resident satisfaction, and family satisfaction, and comparing those by different regulatory frameworks that are used by states. And I think continuing to have the conversations like we're having here is an important part of it, and expressing what your interests, needs, frustrations, and questions are to the licensing agency staff is also an important approach.
Thank you. So we're approaching 2 o'clock, but I'm going to do 2 more questions quickly. Here's one. At one point, this is from Peg Graham. At one point, there were reports, that assisted living admission criteria made it very difficult for people with mobility disability, and for example, needing help to ambulate, toilet transfer, to access most assisted living facilities. Have you found that in your work?
We are looking at admission criteria, and it does vary. And what you find in some states is that they might have like a level 1 and a level 2 or level 3, or different things like that. And level 3 is might have higher staffing requirements and have the capacity to help people even who have a 2-person transfer assist type of need. So it just one assisted living is not like another assisted living is what it comes down to. It depends. They might look very similar. They might even have the same name, but they might have a different licensure designation. So it really requires digging into that.
Thanks. And I'll just do one more question, if that's okay. This is from Francis Duffy. Why do we not push for ALs to be designated as medical facilities? Would this not change the ball game?
Well, I think the way I think about assisted living is somewhat more like home health being delivered in the home. And homes can provide very high level of medical, health related care, but we don't designate those as medical care facilities. I think what we just need is the oversight structure, and the support from clinical care. We don't have to turn them into medical care facilities, but provide the support when needed.
Thanks so much. So thank you again. Really, I'm thinking about so much just as a result of some of the things that you spoke about. Great materials. Again, this will be posted. The recording will be posted on our website and YouTube channel by the end of the week. But I believe the materials are already up on our website, so you can go to the links that Paula gave us. Thank you again, Dr. Carter, and thank you everyone for joining us. We'll see you next month. Bye-bye now.